Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 152 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, LHB, a 35-year-old male patient was admitted to the surgical intensive care unit 4 days ago following a motor vehicle accident, abbreviated as MVA. He required initial mechanical ventilation. Since day 3 of his hospitalization he has been able to breathe on his own and was subsequently extubated. He has received vancomycin and piperacillin, tazobactam for extensive lacerating skin wounds he received during the MVA through a central line. He has no significant past medical history. So my question to you is, given this information, how many risk factors does LHB have for healthcare-associated methicillin-resistant Staphylococcus aureus, abbreviated as HAMRSA? Does he have A. 5, or B. 4, or C. 3, or does he have D. 2 risk factors for healthcare-associated methicillin-resistant Staphylococcus aureus infection? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. He has 2 risk factors for healthcare-associated methicillin-resistant Staphylococcus aureus infection. Risk factors for HAMRSA infections include the presence of indwelling catheter, hemodialysis, prolonged hospital admission, extended antibiotic use, and admission to a critical care unit or other closed medical unit. This patient has an indwelling central line and has been admitted to a critical care unit, thus, he has 2 risk factors for HAMRSA infection. That makes answer D correct, and answers A to C incorrect. Because he has only been admitted to the hospital for 4 days, he does not yet have a prolonged hospital course or prolonged antimicrobial use. Please advance to the next question. And the next question reads, WJS, a 26-year-old female patient lives with 2 preschool-aged children who attend day care. 120 days ago, she received appropriate treatment for a large carbuncle on her back with incision and drainage, abbreviated as I&D, plus oral clindamycin. 60 days ago, she had a furuncle on her right arm which was managed by an I&D alone, after which she was counseled to use environmental hygiene measures to decrease the risk of another infection. Today, she presents to her primary care provider, PCP, again for evaluation of a furuncle on her left thigh. She claims to strictly adhere to environmental hygiene. Her PCP performs another I&D and is considering decolonization in WJS's case due to her repeated infections. So my question to you is, which of the interventions listed below would be the most appropriate therapy for WJS at this time? Would it be A. She should be prescribed co-trimoxazole plus rifampin for 2 weeks for decolonization because of her repeated infections, or B. She should be prescribed nasal mepiosin twice daily for 1 week and counseled to use chlorhexidine washes for 1 week, or C. She should be prescribed clindamycin for 1 week for treatment of the furuncle, but no decolonization is required at this time, or would it be D. No further treatment is warranted now since she doesn't yet meet the criteria for decolonization. I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. She should be prescribed nasal mepiosin twice daily for 1 week and counseled to use chlorhexidine washes for 1 week. Recurrent skin infections are defined as 2 or more skin and soft tissue infection episodes, abbreviated as SSTI, in a 6-month period. This patient has had 3 episodes in 4 months, thus, she has a recurrent infection. The source could be her children, who attend day care. Decolonization procedures are recommended for patients with recurrent infections who use appropriate hygiene techniques, which this patient claims to be doing. That makes answers D and C incorrect. Oral antimicrobials are only recommended when infections recur despite topical colonization strategies. That makes answer A incorrect. These infections should be decolonized with at least nasal mepiosin, and because she has had infections on 3 distinct body areas, chlorhexidine or bleach baths would also be reasonable for topical decolonization. That makes answer B correct. Please progress to the next slide. And the next question reads, ATG, a 57-year-old male patient presents to your accident and emergency department for evaluation of several large blisters on his right arm. He informs the emergency medicine physician that the blisters were raised and filled with what looked like clear fluid but that they began to burst earlier today. The lesions have become very edematous with crusting formation around the edges. He has a past medical history significant for hypertension and dyslipidemia. He has no known drug or food allergies. So my question to you is, which of the regimens listed below would be the most appropriate therapy for ATG at this time? Would it be A. Cephalexin for 1 week, or B. clindamycin for 10 days, or C. co-trimoxazole for 1 week, or would it be D. mepiosin applied to each lesion twice daily for 5 days? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Cephalexin for 1 week. Given the patient's clinical presentation, he probably has ectyma. Topical therapy is not recommended for ectyma because the lesions are deeper, and this patient's lesions are described as large, making answer D incorrect. Ectyma is usually caused by Streptococcus pyogenes or MSSA, so empiric therapy is directed toward these organisms. MRSA is not a common cause. Bactrim, clindamycin, and doxycycline are only recommended when the culture and sensitivity, C and S results are positive for MRSA or the patient is at high risk, making answer C incorrect. This same rationale applies for clindamycin, making answer B incorrect. Clindamycin could be used as a beta-lactam alternative if the patient had allergies, but this patient does not. Therefore, answer A is most appropriate. Please proceed to the next question. And the next question reads, COW, a 22-year-old male first-year college student presents to the college clinic with a chief complaint of a large boil on his back, which has steadily grown larger over the past 3 to 4 days. His pertinent vitals include a body temperature of 37.1 degrees Celsius, a heart rate of 71 beats per minute, a respiratory rate of 20 breaths per minute, and a blood pressure of 118 systolic and 68 diastolic. He has no significant past medical history. He is allergic to penicillins, and the last time he received amoxicillin he developed a rash. So my question to you is, which of the interventions listed below would be the most appropriate for COW's case at this time? Would it be A. Cotrimoxazole for 10 days, I&D is not needed, or B. I&D plus cotrimoxazole for 1 week, or C. I&D plus cephalexin for 10 days, or would it be D. I&D only? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. I&D only. For purulent skin and soft tissue infections, abbreviated as SSTIs, I&D is the mainstay of therapy and should always be done, making answer A incorrect. Many patients can successfully be treated with I&D alone, but antimicrobials are indicated for some patients, such as when they have signs and symptoms of systemic infection, are at extremes of age, and have moderate or severe infections. Empiric therapy for purulent SSTIs should be an agent with activity against MRSA. This patient has normal vital signs and is otherwise healthy, thus, the patient has a mild infection and I&D alone is preferred. If antimicrobial therapy were indicated, answer C would still be incorrect because it lacks MRSA coverage, and the patient is allergic to penicillins. Answer B would be correct if the patient required antimicrobial therapy in addition to I&D, but because he does not, answer D is correct. Please proceed to the next slide. And the next question reads, LHV, a 52-year-old male patient is brought to your accident and emergency department by his wife. He has a chief complaint of right leg pain and erythema and subjective fever at home. He reports that his leg began to get red 4 days ago after a spider bite and that the redness has slowly been spreading and becoming more erythematous. On examination, his leg is warm to the touch and very erythematous and edematous, but no purulence is noted, even at the spider bite. His pertinent vitals include a body temperature of 38.1 degrees Celsius, a heart rate of 96 beats per minute, a blood pressure of 132 systolic and 88 diastolic. A comprehensive metabolic panel, abbreviated as CMP, and complete blood cell count (CBC) show white blood cell count (WBC) of 14.4 times 10^3 cells per millimeter cubed, with neutrophils accounting for 85%. All other laboratory values are within normal limits. He has a past medical history significant for hypertension and thyroidectomy. He has no known drug or food allergies. So my question to you is, which of the microbes or pathogens listed below is LHV most likely infected with? Is it A. Streptococcus agalactiae, or B. Methicillin-resistant Staphylococcus aureus, MRSA, or C. Methicillin-sensitive or susceptible Staphylococcus aureus, MSSA, or is it D. Streptococcus pyogenes? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Streptococcus pyogenes. This patient has the traditional signs and symptoms of cellulitis, and his case should be considered severe because of his high temperature, heart rate, respiratory rate, and WBC. The infection is probably not necrotizing fasciitis because it appears to be progressing slowly. Streptococcus pyogenes is the most common cause of cellulitis. That makes answer D correct. Staphylococcus species, whether MRSA or MSSA, are unlikely causes, and because this patient has no area of purulence, they are incorrect, making answers B and C incorrect. Streptococcus agalactiae typically affects neonates and pregnant women and only rarely causes skin and soft tissue infections, SSTIs, making answer A incorrect. Please proceed to the next question. And the next question reads, which of the options listed below would be the best recommendation for LHV at this time? Would it be A. Admit to the hospital and initiate empiric treatment with ciprofloxacin, or B. Admit to the hospital and initiate empiric treatment with vancomycin and piperacillin, tazobactam, or C. Perform I&D on the infected area in the A and E, discharge to home with oral clindamycin, and follow up with primary care provider, PCP in 3 days, or would it be D. Recommend discharge to home with oral penicillin VK for 10 days, follow up with PCP in 7 days? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Admit to the hospital and initiate empiric treatment with vancomycin and piperacillin, tazobactam. Patients with severe cellulitis should be admitted to the hospital for broad antimicrobial treatment, making answers A and B incorrect. Also, I and D is incorrect because there is no focus of purulence to drain. Answer A is incorrect because ciprofloxacin is not a recommended treatment of cellulitis, according to the Skin and Soft Tissue Infection SSTI guidelines. Ciprofloxacin works primarily against gram-negative organisms, and though those should be covered in a patient with severe cellulitis, the most likely cause is gram-positive organisms. Therefore, ciprofloxacin alone would not provide appropriate coverage. Vancomycin plus piperacillin, tazobactam provides broad-spectrum coverage against gram-positive and gram-negative organisms and is recommended by the guidelines, making answer B correct. Although Streptococcus pyogenes is the most likely cause, because this patient has severe disease, it is recommended to empirically cover with broad-spectrum agents for added coverage against other pathogens, even if they are unlikely causes. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 153.